So I guess I can do the overview. I do have an overview slide of who we're talking about. So I'm going to talk about molecular testing of lung cancer at the beginning of our session, just very briefly to say what are the tools and technologies that we are using in order to diagnose lung cancer. We can't treat it the right way if we don't understand everything about it. Then we'll have Dr. Millie Das. Thank you, everybody. We'll have Dr. Millie Das talking about targeted therapies with metastatic lung cancer. Mohana Roy for early stage lung cancer and targeted therapies that are emerging into the early stage setting. Dr. Mayal with other emerging therapies that weren't covered in the other sessions, plus brain metastases. And Dr. Ramchandran talking about managing side effects of therapy. Of course, we want therapies to be effective and very tolerable. And then we'll have a panel including Dr. Bryant Lin and Jackie Areto. So let's think about a case. Case of a 50-year-old woman who presents with a cough initially, a never smoker. One cigarette doesn't count as a smoker. You can have up to 100 apparently, or be around a little bit of secondhand smoke, and still be considered a person without a smoking history. CT scan, this is commonly what we see, which is multiple bilateral lung nodules, so little tiny dots. We can see some vessels in there, but we also see little dots on both sides and some fluid and a mass over on the left side of the CT. Biopsy shows poorly differentiated lung cancer, adenocarcinoma. We do full staging with those tools that we talked about earlier, MRI of the brain with contrast, PET CT looking for distant metastases. Fortunately, don't find any. What do we do as the next step? So this used to just be called non-small cell lung cancer, but now we've actually subdivided it. As Mark Berry talked about, the stages of lung cancer, we divide them into the early stage, the advanced stage, and the locally advanced stage, sort of stage 3. And we can use different tools to treat each of these. So for early stage, we think about surgery or even definitive radiation, as Dr. Vitztham talked about. Then we start to add chemotherapy as the tumors get more advanced and spread to the lymph nodes. We think about involving radiation if surgery is not as feasible. And then for stage 4 lung cancer, the problem is it can spread anywhere the cancers can go. The lungs, the pleural space, the brain, the adrenals, the bone, the liver. And so between 20 and 40,000 Americans will develop lung cancer without a smoking history every year, and more than half are metastatic. So we have to look inside the cancer and look for the DNA mutations that make up the cancer. These are not mutations that were in a person pre-existing usually. These are abnormal changes in the DNA within the cancer cells. And they cause gain of function mutations of something called a proto-oncogene turning into an oncogene, or they can cause loss of function of some of the normal checkpoints that stop cells from reproducing abnormally. So we look inside this ball of cancer cells, which has many different gene mutations, isolate the DNA, and look for these mutations. Oncogenes, you said? All right, well, a doctor special for oncogenes here in the window actually Googled oncogenes. And I also found some oncogenes, but apparently these are like Ginkgo genes or something like that. But the AI algorithms thought it said oncogenes. So there you go, they make them. So we need mutation testing to show targetable driver oncogenes. The most common one of the first identified was EGFR common mutations. But now we have multiple different mutations, gene rearrangements, all activating these pieces of DNA creating proteins that are like a switch turned on and always signaling. And we can actually take advantage of these with pill therapies to try and treat it. So the green ones here are usually not smoking associated in the theme of today's meeting. How do we test for targets? At Stanford, we've actually used many of these testing methods over the last few years. Direct sequencing of the DNA. We've done protein testing on the outside of the tumors. We do NGS now, multiplex testing, looking for hundreds of genes all in parallel. We've moved to liquid biopsy-based testing, as well as RNA-based testing, where we can find the product of the DNA making RNA, which is a little bit more specific for finding some of the big rearrangements. So we have in-house testing right now based on PCR, based on DNA multiplex, and based on RNA as well as some plasma sequencing that we do here at Stanford for our patients. We can do workups with liquid biopsies. Liquid biopsies involve finding DNA pieces, RNA pieces, protein pieces, as well as other bits of the cancer that may be floating around. And a lot of our focus now is to find these bits in early stage lung cancers to try and cure them earlier. Lots of different therapies for non-small cell lung cancer. I think of these as the three pillars: the chemo on the left, the targeted therapies in the middle, both antibodies and small molecule pills, and immunotherapies over on the right, with the future hopefully having cellular therapies or bispecific T-cell engagers. And now we have some antibody drug conjugates in purple down at the bottom that are kind of halfway in between a targeted therapy with chemo focused and brought straight to the cell. We have 11, as of when I updated this about a month ago, 11 approved targets with therapies in non-small cell lung cancer. There will not be a test on the slide at the end, but we're going to dive into some of these during this. So this patient probably has a targetable alteration, probably can be offered a tyrosine kinase inhibitor pill, and here are some examples of ones that we use. And we hope that these pills work forever, or at least the cancer melts away for many years with a high quality of life. So we say it takes a village to do this, and we'll have part of our village up here, but I like to think it takes a farm, because we're on the farm right now. So introducing you to some of the members of the farm family here, our thoracic oncology fellows at the bottom, some of the attendings who are here at the top, as well as many others who work in our group in clinical research and over in the clinic for nursing and et cetera. And these pictures were courtesy of Heather Wakely, who has her famous selfie arm, best capitulated by the COVID social distancing down to the right, where we're all nervously standing 6 feet apart. So thank you very much, and I'll pass the microphone to Millie Doss.